Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient arrives with sudden right-sided weakness and expressive aphasia. The first thing you are trying to decide is not only, is this a stroke, but also, is this hemorrhagic or ischemic? Is there a large vessel occlusion, and is there still brain tissue that can be saved? An ischemic stroke means a focal neurological deficit caused by occlusion of a cerebral artery, leading to brain infarction. The key word is focal. The deficit reflects the part of the brain supplied by the blocked artery. The pathophysiology is very high yield. A thrombus or embolus blocks an artery. That causes reduced cerebral perfusion. Reduced perfusion means reduced oxygen and glucose delivery. The neuron then loses ATP. ATP failure leads to failure of the sodium-potassium pump. Sodium and water move into cells, causing cytotoxic oedema. At the same time, glutamate excitotoxicity and calcium influx activate destructive intracellular pathways. The end result is neuronal death. This gives us the concept of the infarct core and the penumbra. The core is already irreversibly infarcted. The penumbra is electrically silent, but potentially salvageable if blood flow is restored quickly. That is the reason behind the phrase, "time is brain." It is not just a slogan. It means every minute of persistent occlusion converts potentially salvageable penumbra into permanent infarction. Now think about the common causes in simple folders. One folder is cardioembolism, especially atrial fibrillation. A clot forms in the heart and travels to the cerebral circulation. Another folder is large artery disease, especially carotid atherothrombosis. Another is small vessel disease, where lipohyalinosis affects deep penetrating arteries. Then remember the less common but important causes, arterial dissection and hypercoagulable states. When you see the clinical features, do not memorize them as random symptoms. Deficits map to vascular territory. The Oxford Stroke Classification is a bedside clinical classification that helps predict the territory involved. But MRCP trap, it does not replace CT or MRI, and it does not replace vascular imaging when you need to look for a large vessel occlusion. The Oxford classification divides ischemic strokes into 4 clinical groups: TACI, PACI, LACI, and POCI. TACI means total anterior circulation infarct. Think of a big anterior circulation stroke, usually involving the middle cerebral artery or internal carotid territory. To call it TACI, you need all 3 features: contralateral weakness or sensory loss affecting the face, arm, and leg, homonymous hemianopia, and a higher cortical dysfunction such as aphasia, neglect, apraxia, or visuospatial impairment. In simple terms, TACI is the big MCA-type stroke. Motor and sensory pathways, visual pathways, and cortex are all involved. PACI means partial anterior circulation infarct. This is a smaller anterior circulation stroke. It may have only 2 out of the 3 TACI features. It may present as isolated cortical dysfunction, such as aphasia alone, or it may have a motor or sensory deficit that is less extensive than TACI, for example, face and arm weakness without leg involvement. Think of PACI as a smaller branch MCA stroke, where only part of the anterior circulation territory is affected. LACI means lacunar infarct. This is a small vessel deep infarct, typically affecting structures such as the internal capsule, thalamus, pons, or basal ganglia. The key clue is that there are no cortical signs. So there should be no aphasia, no neglect, and no visual field defect due to cortical involvement. Classic lacunar syndromes include pure motor stroke, pure sensory stroke, sensory motor stroke, ataxic hemiparesis, and dysarthria clumsy hand syndrome. The mechanism is deep small vessel occlusion, so the presentation is often clean and stereotyped. POCI means posterior circulation infarct. This involves the vertebrobasilar territory, including the brainstem, cerebellum, and occipital lobes. The symptoms often feel different from anterior circulation stroke. Think about diplopia, dysarthria, dysphagia, vertigo, ataxia, nystagmus, and cranial nerve palsies. A very important posterior circulation clue is a cranial nerve deficit on one side with contralateral limb weakness or sensory loss. Bilateral weakness or sensory signs can also occur. Homonymous hemianopia can happen with a posterior cerebral artery infarct involving the occipital cortex. A rough way to remember the locations is to use the brain picture as a memory map. Total anterior means a large front and middle territory. Think frontal cortex, eye or gaze involvement through the frontal eye fields, and sensory motor cortex involvement, giving face, arm, and leg deficits with cortical signs. Partial anterior is a smaller chunk of the same anterior territory, so the cortex symptom or the eye and visual field component may be missing. Lacunar is deep, sitting in structures such as the internal capsule, thalamus, basal ganglia, or pons, slightly behind and underneath the cortex on the diagram, so you get pure motor or pure sensory patterns without cortical signs. Posterior means the back and base of the brain, brainstem, cerebellum, and occipital cortex. So think diplopia, dysphagia, vertigo, ataxia, cranial nerve signs, and posterior visual field problems. So the very quick memory is this. TACI is a big anterior stroke, weakness, hemianopia, and a cortical sign. PACI is a partial anterior stroke, incomplete TACI or isolated cortical dysfunction. LACI is a small deep stroke, pure motor or sensory syndrome with no cortical signs. PI is a posterior stroke, brainstem, cerebellar, or occipital signs. Now move to diagnosis. Suspected stroke is an emergency. Start with ABCDE, check glucose immediately, identify the exact onset time or last known well time, and assess severity using the NIASS. Check swallow early because aspiration is a major preventable complication. Get ECG or telemetry because atrial fibrillation may be the cause. Do bloods, but do not allow routine bloods to delay urgent imaging when the patient may be eligible for reperfusion. Urgent non-contrast CT head is mainly done to exclude hemorrhage. Early ischemic changes may be subtle or absent. CT or MR angiography is used to identify large vessel occlusion. Perfusion imaging can identify salvageable penumbra, especially when considering thrombectomy in extended windows. MRI diffusion-weighted imaging is very sensitive for early infarction. The immediate treatment pathway should be automatic. Suspected stroke means ABCDE, glucose, onset time, NIS, and urgent non-contrast CT head. If CT shows bleeding, do not give thrombolysis and do not give aspirin. Reverse anticoagulants if needed, control blood pressure according to stroke protocols, and involve the stroke and neurosurgical teams early. If CT shows no bleed, move into the ischemic stroke pathway. The first question is this patient a thrombolysis candidate, and are there contraindications? If they are within the thrombolysis window and there is no contraindication, give intravenous thrombolysis. MRCP trap, do not give aspirin at the same time. Avoid antiplatelet and anticoagulant treatment for the first 24 hours after thrombolysis. Repeat CT or MRI, or otherwise exclude hemorrhage at 24 hours, and then give aspirin 300 milligrams if safe. The second question is, could this be a large vessel occlusion? Big stroke signs include NIHS more than 5, aphasia, neglect, gaze deviation, dense weakness, visual field loss, or basilar artery features. In these patients, arrange CTA head and neck immediately. This can be done with the first CT, but it should not delay intravenous thrombolysis if thrombolysis is indicated. It can even be performed while thrombolysis is running. If large vessel occlusion is confirmed, call the thrombectomy center. Thrombectomy is usually within 6 hours, but may be considered up to 24 hours where imaging shows salvageable brain. If the patient is not a thrombolysis candidate and CT has excluded hemorrhage, give aspirin 300 milligrams immediately. That is a common exam point. Aspirin is delayed if thrombolysis is given, but started immediately after hemorrhage is excluded if thrombolysis is not being used. Finally, treat the cause. Do not stop at the acute scan. Look for atrial fibrillation and anticoagulate when appropriate and safe. Treat hypertension, diabetes, lipids, and smoking risk. Consider carotid endarterectomy if there is relevant carotid stenosis. Manage glucose carefully, avoid fever, protect swallowing, and start rehabilitation early. If you remember one thing, remember this. Acute stroke management is about excluding hemorrhage, identifying salvageable brain, restoring blood flow when possible, and preventing early complications and recurrence. Quick recall. A patient presents with sudden left-sided weakness affecting face, arm, and leg, a left homonymous hemianopia, and neglect. Which Oxford stroke category is this, and what does it suggest anatomically? The answer is TACI, a total anterior circulation infarct, suggesting a large anterior circulation stroke, classically a large MCA or internal carotid territory event. A patient has a dense pure motor hemiparesis with no aphasia, no neglect, and no visual field defect. CT excludes hemorrhage, and the patient is not suitable for thrombolysis. What is the likely Oxford category, and what immediate antithrombotic step should be taken? The answer is LACI, a lacunar infarct, and aspirin 300 milligrams should be given immediately once hemorrhage has been excluded. Do subscribe to the channel for further videos.